Welcome to Pulmonology Read Aloud. This is Dr. Ansham, and I will be taking up the part 2 of the series on the European Respiratory Society guideline statement, the consensus on treatment in non-malignant pleural effusions. And today we'll be talking about refractory heart failure, hepatic hydrothorax. So these two, which are common causes of recurrent transudative effusions, will be dealt with in this talk. Before I begin, I would like to extend my thanks and my gratitude to all of you whom I recently met at BronchoCon 25 in Delhi. And it was really overwhelming to hear about your experience with the channel. Thank you very much, and I hope that this video also helps you. Now, this is a simple flowchart that basically summarizes what we discussed in our last talk. When we are dealing with pleural effusion of unknown etiology, we all know that the first thing that we have to do is evaluate the Lights criteria. So, to summarize my previous talk, when you are evaluating the Lights criteria, if the pleural fluid to serum protein is more than 0.5, the pleural fluid to serum LDH is more than 0.6, or the pleural fluid LDH is more than 2/3 of the upper limit of normal, it's a clear cut exudate. But if you come across a situation where the criteria for the exudate are not completely met, but they are close to the cutoff point, then this is what you will be doing. In such a case, you will see whether there was a high pretest probability that this patient is a heart failure or this patient is a cirrhosis patient. Also, history wise, you would know whether this patient has an acute onset febrile illness followed by the effusion, say a symptomatic effusion, or it's just a patient with cardiac failure coming up and talking about breathlessness. So, if that is the case and the Lights criteria, the initial ones, don't help you, then what can you use in heart failure as well as hepatic hydrothorax effusions? You can use, firstly, the albumin gradient. If this pleural fluid, the serum to pleural fluid albumin gradient is more than 1.2, there is a high likelihood of this being a transudate secondary to the cardiac effusion. If the pleural fluid to serum albumin gradient is less than 0.6, there's a high chance that this is cirrhotic or hepatic hydrothorax related effusion in a patient with cirrhotic liver. If the NT-proBNP in the pleural fluid or the serum is more than 1500, there's a very high likelihood, or rather almost diagnostic, that this is a transudate, which is because of heart failure. And if the score for exudates of cardiac origin, the scoring, as I had mentioned from Porcel scoring system, is more than 7, again, it signifies it's a transudate. So if none of these criteria were met, it's a clear transudate. If you have a doubt, then you do these criteria further, and one of the Lights criteria is met, becomes an exudate. So this is what we discussed last time, and here we also gave two different values where if you don't have a serum sample, then just a pleural fluid LDH more than 2/3 of the normal upper limit normal serum LDH can be seen, or a pleural fluid cholesterol more than 55 can be taken as an exudate. Moving on, in this talk, we'll be talking about refractory effusions. Now, this group of the team, the consensus statement team, they took almost 1,000, more than 1,000 studies, and they screened them. And they identified almost 34 studies relevant to producing this section on refractory effusions. So they had seen certain editorials, certain narrative reviews, guidelines, and almost 12 retrospective studies and 6 prospective studies with 3 RCTs to come to a conclusion of how we can manage refractory effusions. So a refractory effusion essentially is those which are refractory to medical treatment and where you need a palliation of symptoms, and for that you may require pleural interventions. So, those effusions in a heart failure patient, in a kidney disease patient, in a cirrhotic liver patient, or those effusions where it is not recovering just by the medical management of diuresis or dialysis or otherwise, will be termed as refractory effusions. What are the options of management that we have here? One option is to repeat ultrasound guided thoracentesis. So whenever patient gets symptomatic, you can repeat a thoracentesis and the patient will get better for a short while and may have symptomatic relief. The second option is to have an indwelling pleural catheter, which again, based on patient symptomatology, can be drained, and the patient or his family can drain some fluid till he gets a symptomatic relief. The third is to perform chemical pleurodesis, and chemical pleurodesis is mostly performed in non-malignant settings and otherwise in India and I'm sure abroad as well, with either uh, providone iodine, which is a very good pleurodesis agent, or talc, which can be in the form of talc slurry or talc pudraj. These are the most common ones. Of course, when we talk about malignant pleural effusions, there are many others, but according to certain recent research, they found talc and providone iodine to be one of the most commonly used and successful agents amongst many others. The fourth option you have is surgical procedure, a surgical pleurodesis, which can be done VATS guided also. And the last or the most extreme or the of these procedures is doing a pleuroperitoneal or a pleurovenous shunt. So let's talk about these a little in detail. What is the practice by the team of authors? So they've basically said that when you're dealing with refractory fusion, it really depends on the setup, it depends on your patient. But what they say that this is what our consensus is that most of us do. They would repeat the pleural aspiration for recurrent symptomatic cardiac effusions or do a chest tube drainage. So when we're talking about a heart failure refractory effusion coming back again and again, they would either keep on tapping the patient as and when he comes and continue to optimize his medical management, or if it's a large volume effusion, sometimes it may need a drainage via chest tube or a pigtail. They would consider other treatments only if this strategy does not work or you are requiring frequent reintervention. So, if in a recent span of time the patient has come to you with more than 3 repeated thoracentesis, then you would go ahead and think about pleurodesis and other IPC and other interventions. The reason is that the only evidence in the form of an RCT till date, which evaluates outcomes of repeating a thoracentesis, a therapeutic one, is there is one which talks about that versus an indwelling pleural catheter, and they have seen that when you talk about symptomatic pleural effusion secondary to cardiac, renal, or hepatic failure, they looked at whether a patient having an IPC or a sequential therapeutic thoracentesis had any significant difference in results, and they noticed that there was no significant difference in breathlessness for the two procedures. So the primary outcome, whether you're talking about a significant difference in breathlessness, is not very different, despite that the IPC group will have a better drainage as compared to the group which has just therapeutic thoracentesis. And we also know that IPC has its own adverse events, sometimes in the form of cellulitis in the skin, and also they consider that there's not much significance if you look at symptomatic relief being the major determinant. But obviously, having an indwelling pleural catheter will have other significant changes in the sense that the patient will have less hospital stay, or the patient will be more comfortable to do repeated drainages. So, based on that study, which was by Walker and et al., which was called REDUCE study, Refractive Transudative Pleural Effusion study, there was no significant symptomatic change between the two. And based on this, they say that you can very well do repeated therapeutic thoracentesis unless it's something which is too frequent. So, the IPC versus thoracentesis trial, which is one randomized controlled trial, has not shown any advantage of dyspnea relief. And retrospective studies talk about palliation of symptoms and reduced length of hospital stay with IPC. So, you consider it when it's beneficial when you have frequent thoracentesis. There are no studies that compare cardiological and pleural interventions for patients with recurrent pleural effusion due to heart failure alone. So, most studies have just extrapolated data in a small subset of patients. Therefore, the consensus is still not very clear, but the consensus still says that when you do pleural interventions, you should do it only if they are refractory to medical treatment. Versus talc pudrage or pleurodesis, the chemical pleurodesis. The authors have mentioned two retrospective studies that compare talc pudrage with or without IPC placement versus IPC alone. And they have not seen any significant difference again in symptom relief between the two techniques. But when a patient undergoes a chemical pleurodesis in the form of talc pudrage, he will have a longer hospital stay. He may come back with readmissions, and he may have a higher mortality and morbidity. Plus, rate of pleurodesis, if we talk about between talc pudrage and IPC, obviously talc pudrage will give you a pleurodesis, which IPC may not. So, there is a difference in terms of morbidity, but when you talk about symptom relief, it's almost similar. And patients who had IPC alone, they could keep the catheter in for a longer time. So that's the difference that comes out of these two retrospective studies. Talking about surgical approaches in heart failure specifically, they've been rarely attempted for patients with heart failure because they are very frail patients, they have comorbidities, they often will not get the anesthesia clearance for a major procedure. So, we would rarely be going forward and doing those if none of this above can be done. So this is a flow chart again, which simplifies what we've just discussed. If you have, and this flow chart is very special in a unique way that it talks about single-sided effusions in heart failure patients. Now, often when we talk about transudates, we think about bilateral effusions, but we very well know that there will be circumstances when you will have a unilateral effusion, and then one tends to be more confused whether this is actually a true transudative effusion or an exudate. So, first of all, if you have a unilateral pleural effusion in a patient with known heart failure, you will clinically assess and see whether the findings are consistent with heart failure causing effusion or to an alternative diagnosis. So, whether the patient had fever, whether he had pneumonia, whether been a weight loss, whether there was an acute fever, chest pain, elevated WBC count, elevated CRP, or could it be another cause of this unilateral effusion? For instance, could it be a malignant effusion or a pleural infection? Now, if that is yes, then you would obviously, because it's some other cause, you will do a diagnostic or therapeutic thoracentesis. What happens if this is not true? So you again feel that this patient could be having this unilateral effusion secondary to heart failure. If you consider treating as heart failure, you check whether your patient is clinically stable. If your patient is clinically not stable and you think this is heart failure related, you go ahead and do diagnostic therapeutic thoracentesis. If your patient is stable and you can wait till you manage this effusion, then you just optimize his medical treatment, his heart failure, and reassess the patient. If he's reassessing, then don't do any pleural intervention. Now, in a scenario where again there is no alternative diagnosis to this unilateral effusion, and features are supporting heart failure as a cause of effusion, you can do a thoracic ultrasound and you can do a cardiac echo, and again try to ascertain if there are findings suggestive of cardiac cause as a cause of effusion. So you will see a lot of B lines in the ultrasound image. You will see a present sliding sign present. You will not see an underlying consolidation. And when you keep the probe on the heart, you may see a low ejection fraction. You may see a pericardial effusion. So all of these will suggest that yes, this patient has effusion secondary to cardiac cause. And remember, we talked about NT-proBNP, which will be a very good tool. So you can do either a serum NT-proBNP or you can do a pleural fluid NT-proBNP level. Has it elevated now? Has it changed? Or is it more than 1500? If it is, then this is most likely cardiac failure, and that's how we will manage it. So these are the findings that I have roughly just mentioned. When you can do a non-invasive test, which is the ultrasound and the echo, and use it along with NT-proBNP as a biomarker and complete your assessment for that fluid. And we know that you would see a lot of findings which are suggestive of cardiac failure, systolic and diastolic, and no apparent findings of other causes. Also, you can assess the inferior vena cava to see whether it's full, it's grossly dilated to see whether the CVP is high, and again you will see that is suggestive of a cardiac failure. Coming to the next component of this statement, which is now regarding refractory hepatic hydrothorax. Now you know that hydrothorax secondary to liver disease is very common. It's also very disabling. A lot of patients also have ascites along with it, and usually patients have a very poor prognosis. Now, mostly we try to manage them with medical therapy, and medical therapy would be again just like heart failure, salt restriction, or a diuretic therapy. But there will be almost 1/4 of patients who will have a refractory disease. So, a disease which will not respond to your medical therapy, and here you will have to do certain procedural intervention. Now, so this effusion that occurs in the context of advanced liver disease without cardiorespiratory cause will be called as refractory hepatic hydrothorax, right? And there was one study by Hung et al., which was one of the largest study which evaluated therapeutic thoracentesis, which has been mentioned in the consensus statement, and they examined a Taiwanese insurance registry, and they looked at data to evaluate what is the survival outcome in a patient who's undergone therapeutic thoracentesis for hepatic hydrothorax compared to somebody who's had a catheter in situ and a catheter drainage. They did not about which catheter, what French did they use, but most of these patients had pigtails. So basically 1200 odd patients where they looked at whether you should just tap it or you should leave a pigtail, and they looked at 30-day mortality. So this 30-day mortality was significantly higher in a group who had the pigtail in situ compared to those who underwent just a thoracentesis. So there have been these strange results, wherein you will have a lot of doubt in doing what will be the right measure in this patient and in decision making. So for that, this guideline consensus statement gives us a lot of evidence to understand. So they clearly say that if you have a patient who has hepatic hydrothorax, if you want to give him temporary relief, you may do therapeutic thoracentesis. If there is this patient who has refractory hydrothorax, recurrent, patient is not able to get repeated tapping done, then the procedure that can be done is TIPS or transjugular intrahepatic portovenous shunting. but it has a higher mortality, and it also shows a good improvement in half of the patients. There is no strict good evidence for chest tubes, for pigtails, for pleurodesis, and surgical approaches in this group of patients. So this is an area which is gray. Obviously, the definitive treatment is hepatic transplant. That's the only curative treatment. So, what the authors say is what they would do is they would refer all patients who are eligible for a liver transplant rather than trying to manage only the hepatic hydrothorax component, because that would be more definitive. But it is still a lot of dilemma for the treating physician, and so the guideline uh, caters to that population group and makes things a little easier. So, what they say is that one, you can do therapeutic thoracentesis, two, you can use IPCs. You can also use indwelling pleural catheters in this group of patients. This is the major non-malignant indication of doing an IPC, and that gives you similar dyspnea control. So you can offer it if your waiting list for a transplant is high. Till then, the patient can be on IPC. If your patient is a non transplant candidate or cannot undergo transplant, and has more than 3 thoracentesis, or you cannot repeat thoracentesis because of bleeding risk or otherwise, then they say IPC will be a good palliative option. So it's very clear. If you can give them definitive treatment in the form of a hepatic transplant, that's better. If you cannot, or the waiting is too long, you can do an IPC. So this is the decision tree for a patient with hepatic hydrothorax. Symptomatic patient, you do a multidisciplinary assessment, you look at other causes, you try to optimize the medical therapy to its best. Then you go for a therapeutic thoracentesis, right? Now you do a thoracentesis, but suppose your biochemistry that turns out is not consistent with the hepatic hydrothorax. Then look at other causes. Could it be a bacterial empyema? Could it be some other cause? And if that cause you can treat, then it'll be better. Now, if this patient has a proven hepatic hydrothorax and continues to have symptoms recurrently, again see, is he a candidate for transplant? If he is, list him for transplant, because he that would be more definitive. But keep doing thoracentesis serially if needed. If he is not a candidate, but this is a disabling symptom, consider whether he's a candidate for TIPS. If he is a candidate for TIPS, again, you may need temporary thoracentesis until TIPS is done. See if it resolves and keep on reviewing him in hepatology. Now, if your patient is not a candidate for TIPS or does not show good response to TIPS, this is the time where you have to get your palliative care team involved, and you could consider an IPC if there are more than 3 therapeutic thoracentesis that are required. So, very, very clear on this aspect, and very, very important to again ascertain that the liver transplant option has been seen. What is the role of TIPS in patients with hepatic hydrothorax? So, TIPS or transjugular intrahepatic portosystemic shunt is a procedure which will be done when you do not have transplant as an option or patient is very symptomatic. The most common adverse event of the procedure itself is hepatic encephalopathy. There is a high risk of infection also. It is a major procedure. So mortality is also high, being 40 to 50% at 6 to 12 months. But it may lead to resolution or improvement of symptoms in up to 50% of the other patients. And so for patients where there's no other option, it may be offered. How about chest tube pleurodesis? Should we do that? Again, there have been lot of agents that have been tested, talc being one predominant one, with studies also mentioning tigecycline and bleomycin. 45% patients with hepatic hydrothorax will have procedure-related complications, infections, renal failures, and mortality. We don't have direct trials addressing this. We are only looking at single center studies and case reports. There's one a trial which has been mentioned in the statement, which looked at 40 patients by Mahmood et al. And they randomized these 40 patients when they came second time in a 1:1 ratio, and they looked at TG cycline versus bleomycin via pigtail. And they looked at pleurodesis failure by reassessing the patient at 3 months, and they noted that TG cycline group had a higher failure rate as compared to bleomycin, and however the side effects were lesser in this group. Bleomycin had more side effects. So the data is very scattered in terms of which agent to use. There have been studies where wax pleurodesis has been done, and there have been studies where they had to do at least 3 pleurodesis sessions to achieve a good pleurodesis in this group of patients. So it's not very easy here. Coming to IPCs, again, as they said, they would avoid it unless they're considering that this patient cannot undergo transplant within the next 3 months and is highly symptomatic. Now, breathlessness reduction, if you're looking at only that as a outcome, then that would be similar to what you would have when you do a therapeutic thoracentesis, but definitely it would make it more comfortable for the patient. They've chosen 10 studies of IPC and 2 larger studies with sample sizes of 62 and 79. And they've reported that after transplant, if these patients could be sent for transplant, uh, majority of patients would have a removal of their IPC. So that would improve after transplant. However, some would still continue to have them. And in such a scenario, patients sometimes, if they do not meet the right criteria for pleurodesis also, then IPC may be offered. We have to watch out for infection, especially pleural infections, catheter site cellulitis. So they would want to avoid it unless they know that it is something that they are doing for alleviating patient symptoms and a patient is not going to get a transplant soon. So, a careful evaluation in a multidisciplinary fashion, which will include palliative care teams, is very important before you go ahead and do IPC. In my next video, I will be talking about end-stage renal failure, peritoneal dialysis associated effusions, benign asbestos related effusions, post-surgical effusions, and non-specific pleuritis. I hope this video helped you. If there's any more clarification, you can comment and message me. Also, this guideline is freely available for download online. Thank you very much. Do keep subscribing. Meet me at conferences and let's discuss. Thank you. Bye. And have a good day and happy reading.